Good afternoon, IS sir.
Good afternoon. Are you starting?
Yes, sir. So the session is live streamed already.
Okay.
So in the panelists, you and RSS sir are currently there. Kaushik could join another 10-15 minutes.
Okay.
The attendees will start coming in parallelly. The live link is getting shared.
Okay.
So if we can wait for other 5 minutes to have few more attendees and parallelly get the session started. The first session will be done by RSS sir, followed by Vijayalakshmi madam, then question and answer, then we will open up for the group discussion, sir. So this is going to be the flow.
The first session is on newborn care, is no?
The first session is on birth dose immunization, sir.
Oh,
Vijayalakshmi ma'am is it kind swap. Ma'am is going to do the postnatal after the birth dose, after RSS sir completes.
Oh. Okay. Okay. Yes.
Good
So we
afternoon,
will.
sir.
Good afternoon. Good afternoon. Can you hear me?
Yes, sir. You're audible.
So, sir, can we wait for another 5 minutes or 5 to 7 minutes before starting the session, sir?
Yeah.
What is
Okay. No problem. No problem. Carry
We'll
on.
wait for another 5 to 10 minutes. That's all.
Okay, sir, because students will start joining and parallelly it is live now.
Yeah. Subhashri,
Yes, sir.
what you can do,
Yes,
you,
sir.
you can either play soft music now till it opens and
Yeah.
keep at 1 or 2 minutes intervals announcing it will start in the next few minutes so that they know that we are live. Okay?
Okay, sir. Yeah.
Yeah. In the poster also, you can change to 19th. The date is running as 18th.
Do you want me to change the poster, sir?
Yeah, if it's possible.
Where is the change poster that you have? No, just put it here. It's already shared, sir, with 19th date. Meryl, on the page screen share பண்ணுங்களேன்.
Uh-huh.
Shubhashree?
Yes, sir.
Shubhashree,
Yes, sir.
how you are going to organize the program? The director, the introduction കഴിഞ്ഞ ഉടനെ அரசர் சார் தொடங்கிட்டு வரா இல்லாட்டா அந்த இன்ட்ரடக்ஷனரி ஸ்பீச் கழிஞ்சிட்டு அப்புறம் மெரில் சொன்ன பிற்பாடு நான் ஒன்னு கூட அரசர் என்ன டாபிக் பேசுவார் சொல்லணுமா?
Ama, sir, you have to set the tone for the meeting on birth those immunizations. Then sir will start his presentation.
Okay, fine.
Yeah, that is the
just like yesterday. Fine.
Yes, sir. Yes. Another 2 minutes we can start, sir.
No problem.
Meryl, can you screen share? I think we can get it started. Parallel people can.
Just a second, ma'am.
எடுத்த போல தமிழ் தாய் வாழ்த்தல இருக்கா இல்லையா? Hello?
Sir, you want Tamil Thai means I can add now.
Not necessary. Just the beginning.
Continuation ஆனனால வேணும்னு இல்ல.
Yeah.
Ama, day one play பண்ணியாச்சு. And Oxy player எங்க யாருக்கும் தெரியும். The team is not there. So we will directly start with sir's introduction. Then you can set the tone for the program and we can get it started.
Yeah, just a second. I'm just sharing this.
Shubhashree,
சொல்லுங்க sir.
in order to save some time, just introduce me and I will talk about this session in 1 or 1 minute, and then I will talk this. Then Meryl, Meryl will introduce Dr. Arasar, and then I will set the tone. Okay, fine.
Correct, sir.
I will ask Meryl to invite. Okay, fine. Good.
So are we starting, sir?
We can definitely.
Arasa sir, can we get it started, sir?
Ready?
Can I get it started, sir?
Yeah.
Screen share போட்டுட்டீங்களா? இப்போ screen share. வேணுமா?
Okay, sir. So I'm getting it started now.
Yeah.
Okay.
Good afternoon, everyone. A very warm welcome to all the faculties and participants who have taken their time out and joined us for today's webinar. Ekam Foundation, in collaboration with Oxy and Unicef, have come together in presenting this Day 2 webinar series on Make Pregnancy Safe for Frontline Health Workers, which is focusing on skill upgradation on this core subject. We are very happy and proud in introducing our panelists for today's webinar, moderated by Dr. N.S. Iyer. And our key expert speakers for today is Dr. Arasar and Dr. Vijayalakshmi, followed by the group discussion. I call over Meryl to introduce Dr. N.S. Iyer to moderate the session.
Dr. Iyer is a retired senior obstetrician and a gynecologist of Kerala Government Health Services. He was a former project officer of the Health and Nutrition Unicef Chennai. He was also a former national trainer on the emergency obstetric care of Ogsi-Ekam program. He received the Best Doctor Award in Kerala Government Health Services in 2000. He also received a Lifetime Achievement Award from the Government of Tamil Nadu for the training several batches of newly recruited doctors and staff in TN on ECMO in 2018. He was the first one to introduce the non-pneumatic anti-shock garment in India. Over to you, sir.
Okay. Thank you very much, Meryl. And welcome to all esteemed faculty members, Dr. Arisar and Vijayalakshmi, and also the audience. And the majority of them are actually the backbones of maternal and newborn care, and in any hospital, working always behind the scene. As the PSC medical officers and staff nurses are the first line contact in any emergency situation, there cannot be any limit for their capacity building and improving their skills. So training is always a continuous process. It is indeed a welcome gesture that Oxy has readily agreed to be part of this venture with UNICEF for a series of training program with interactive sessions between the frontline service providers and eminent obstetricians and neonatologists in Chennai. And we have got eminent speakers today. And I request Meryl to introduce Dr. Arisar Siralar, the eminent neonatologist and the director of ICH.
Thank you so much, sir. So may I invite Dr. Arisar, the former director of ICH. Dr. Arisar is an alumnus of the prestigious Madras Medical College. He developed the pediatric ward and established the first newborn unit in the Kilpack Medical College. He has served in various capacities in different institutes across the state. He was evaluator of neonatal and pediatrics facilities for fellowship accreditation for the Tamil Nadu Medical University. He served in the Committee on Prevention of Violence Against Women in Ministry of Social Welfare. Dr. Arisar has also assisted in planning of the SNCU in Tamil Nadu along with State Child Health Nodal Officer. Doctor has also served as a core committee member of NRHM Tamil Nadu Chennai Health. Over to you, sir, to talk on the topic for birth dose immunization.
Okay, and as usual, leading health organizations recommend always that all hospitals and healthcare professionals protect newborn from hepatitis B and also BCG and tuberculosis and also polio through the birth dose immunization, the first line of immunization that is to be given to the babies immediately after birth. And we will be dealing with this subject by an eminent pediatricians and who have just been introduced. I need not say anything further about Dr. Sirala. Just to save time, I am giving over the topic to Dr. Sirala for conducting the program. Thank you very much.
Sir, you're on mute. Arisar sir is on mute.
Yeah.
Yes.
Unmute பண்ணலையா?
Yeah, unmute பண்ணியாச்சு. Am I unmute?
Yeah.
Yes, sir, you're audible.
Yes.
Yeah. Now I'm putting it under. What is the slideshow?
வந்திருக்கு.
F5, sir.
Yeah. Good afternoon, everyone. My special respects to the senior faculty, especially Dr. Iyer, senior obstetrician. My special respects to the UNICEF members and especially Kaushik, members of Ekam who have been instrumental in arranging this webinar, and all my senior colleagues who are participating, especially the Obstetric Association members in this important webinar, which is pregnancy and newborn care, which is part of the maternal and child health care. I think we have a lot to achieve in this, and we have come a long way in achieving a lot of goals, and we are targeting very high standards like in Western countries in achieving this. As part of this, we know preventing neonatal deaths, preventing pediatric death, that is preventing infant mortality rate. One of the main strategies is by vaccinating children and preventing these children from succumbing to the common diseases that are prevalent in the community. And when we come to talking birth dose immunization, it is referring to three important diseases that need to be attended soon after birth. The purpose of attending soon after birth, each has got a unique significance, like hepatitis B infection, which is very rampant and which can cause havoc even in the old age group, then the poliomyelitis, then the tuberculosis. These three diseases, when we need to actually treat children or prevent this infection in these children, we need to start vaccinating these children very early in life, even before they start getting this chances of getting this infection. The hepatitis B infection is the most common thing about this. Why I am saying this, and I've taken it as the first one in this birth dose, is that the time permitted or the time available for preventing this mother to child transmission disease, because in our population about 2 to 8% of the pregnant mothers are carriers of this hepatitis B virus, and these mothers have a chance of transmitting this disease to their newborn babies. And the screening of mothers with hepatitis B surface antigen is not universal, and several times the status of these women are not available. So it becomes mandatory if we need to prevent the newborn from getting the chance of getting infected from the mother, we need to do it very early. Especially, we need to do it within the 24 hours after birth. So the infant have a chance of 90% chance of becoming chronically infected with hepatitis B once they get it in the newborn period. So they get it infected in the newborn period, they have a chance of 90% going for a chronic hepatitis B infection. And this chronic hepatitis B infection leads to liver cancer, cirrhosis, and liver failure in about 25% of these infants who had this chronic hepatitis B. So such is the importance of this hepatitis B infection. So the lot of push is given to see that these children, newborns, are protected from this hepatitis B infection, which may acquire from mother to child soon after birth. Now, this birth dose of hepatitis B, this is given as early as possible. We'll have to give it within 24 hours, especially for all institutional deliveries. It is better, it is planned in the labor ward, even before the baby is shifted out to the postnatal ward. This vaccine should be administered, because the earlier it is given, the higher the protective rate. So preferably within 24 hours. For this, what is used is hepatitis B vaccine. We call standalone hepatitis B vaccine is used for the birth dose. And in May 2011, the government of India adopted the open vial policy for HBV birth dose, because it is coming as a multi-dose vial. And this hepatitis B vaccine, though it should be stored at 2 to 8 degrees centigrade, this is a very, very heat stable vaccine. And effort must be taken to see that this vaccine is available in the labor ward or very close to the labor ward, so that the neonate is getting this vaccine soon after birth. Like yesterday, what has been emphasized in yesterday's program was the babies after birth be given vitamin K. It's one of the important strategies to prevent hemorrhagic disease of the newborn. Similarly, this vaccine should also be given soon after birth, and preferably in the labor ward. And it should be the work should be entrusted to the labor ward staffs, the nurse, and the labor ward, the pediatrician available in the labor ward, or the obstetrician who is in charge of the mother in taking care of this baby. And they are still heat stable, and this open vial policy makes them that they can be kept for about 30 days, even if they are punctured once. The proper cold chain is maintained in the labor ward. So that's the hepatitis B vaccine that is currently available in our institutions. This is a 10-dose vial. Each dose is around 0.5 ml. who are the candidates to receive hepatitis B vaccine? Though we say all newborns should receive this hepatitis vaccine, there is a small caveat. It is given to all stable term newborns. All term newborns should receive that. There's no question, unless there are some comorbidity that makes them admitted into the SNCU, which means babies who are asphyxiated at birth, who are having some severe life-threatening congenital malformations, or very sick with respiratory distress. These babies, term babies, may be left off to be given the vaccine to a later date, but all stable term newborn should be administered this vaccine in the labor ward. And all late preterms, that is more than 34 weeks or more than 2,000 grams, can also be given this hepatitis B vaccine. In whom it should be avoided? In sick neonates admitted to the nursery, and in preterm babies and very preterm babies less than 2,000 grams. The purpose of not giving to this group of babies is to that because in very preterm babies, the immune response is not good for the with the vaccine, and in the other group of these early preterms, the vaccine elicits a very high geometric titer of these antibodies, which we do not know whether it's harmful or beneficial for the baby. So when this is still in the nascent stage of research, these babies, that is babies less than 2,000 grams, who are very preterm, less than 34 weeks, may be left off this group unless you have this condition. If the mother is HBsAg positive, the risk of the transmission of the disease from the mother to the baby is very high. So these babies, apart from the vaccine that they are getting, they should also receive along with the vaccine. The vaccine is given in one thigh, and the hepatitis B immunoglobulin is given in the other thigh. For HBV vaccine, you will have to give it within 24 hours. For the immunoglobulin, you have a time frame that you can give it up to 48 hours, but earlier the better. So these two immunoglobulin and vaccines are given to babies who are born to mothers who are HBsAg positive. So two different sites, and this vaccine is given intramuscular. Now I am showing you the vaccine that is loaded in a syringe. You have to use a 1 ml syringe, and you have to choose a needle which called IM needle, that is a 24 or 25 gauge, which should be 1 inch long, and preferably an auto disable or auto lock, so that you prevent it from getting reused. And you should adopt the policy of 1 syringe, 1 needle, 1 baby for all this both those vaccination. So see, you can see how this hepatitis B vaccine is administered. You see, you'll have to choose the anterolateral aspect of the thigh. So see how this staff is holding the child's leg and chosen the anterolateral aspect of the thigh, and it is given intramuscular. See, the staff nurse has put both her fingers, the index fingers and the ring finger, on exactly the femoral triangle. That's the area that needs to be protected. That's the area where you will have to avoid giving an injection, because you have vital structures like the femoral vein, the femoral artery, and the femoral nerve going in that area where the staff has put her 2 index and ring fingers. So away from that, on the lateral aspect, on the upper part of the thigh, you will have to give this vaccine. So this is intramuscular, given on the anterolateral aspect of the thigh, using a 1 ml syringe. The dose is 0.5 ml of the dose is given. Now, I'll show you one other picture, how sometimes things go wrong if the people are not trained in these vaccinations. You see this child where it has received vaccine. It's a wrong side. This is not the anterolateral aspect of the thigh. And I have not put deliberately one picture where an injection is given in the femoral triangle. That child present with a large hematoma. Lucky, if the injection would have gone IV, then it would have crossed a lot of dangers. So the staff nurse should be very careful in choosing the site of the vaccine. The site of the vaccine is the antral aspect of the thigh, and see that that's the anterolateral aspect of the thigh. Kindly avoid, be careful with the femoral triangle where vital structures are running. And the other thing that I want to impress is, after the vaccination, don't vigorously rub the site of injection. So rubbing the site of injection should not be run. All you need to do is keep that area pressed for 2 minutes. If there is some bleeding, for it to stop. So rubbing the area vigorously should be avoided, because rubbing the area in a small neonate vigorously will cause more harm to the baby. It may sometimes cause even necrosis of the muscles. So the staff nurse, the parents should be told that this site should not be rubbed vigorously. The moment the injection is given and the needle is pulled out, you will have to keep it pressed for about 2 minutes, so that that's a normal bleeding time, and the bleeding stops, and kindly verify whether the bleeding is stopped from the injection site. Then allow the child to go back with the mother. So this is how an hepatitis B vaccine should be given. So this thing where you should not give. Now we go on to the next vaccine. The hepatitis B vaccine, we told you it should be given within 24 hours. Suppose by chance it has been missed, you have a time frame of up to 72 hours to give this vaccine. But earlier you give, the better is the protection. The more the delay you cause, the lesser is the protection. So our aim should be to give it within 24 hours if you really want the prevention of mother to child transmission and this preventing this virus from infecting the baby. Now we go on to the next vaccine, that's the BCG vaccine. The BCG stands for Bacillus calmette-guerin. The thing to know, it's a live attenuated vaccine. It is freeze-dried and in a lyophilized form. It is mainly given for preventing serious form of tuberculosis and leprosy. So it may not prevent pulmonary tuberculosis, but after BCG vaccination, there is a drastic reduction in the serious forms of tuberculosis like tuberculous meningitis, gastrointestinal tuberculosis, renal tuberculosis. All of them have come down, and this has been achieved by giving BCG vaccine at birth. And this protection lasts for more than 15 years. Now, this is the BCG vaccine vial, and that's the diluent that is used for reconstituting the vaccine. You can read that in neonate, the dose is 0.05 ml. So 0.05 is equal to 1 drop, and the route of the vaccine is intradermal. So this vaccine is a special vaccine and requires little expertise for the staffs who are administering that, how to administer a intradermal vaccine. And for older children, it is around 0.1 ml. This vaccine should be kept away from light and heat. So that's very, very important. And you will have to reconstitute only with the sodium chloride that is given along with the ampule as a diluent, and it's a buffered sodium chloride so that the pH is adjusted. So it is reconstituted with buffer saline. It should be protected from heat and light, and once reconstituted, must be used within 6 hours. That's very, very important. You cannot keep it for next day or to the next session. Unlike hepatitis B vaccine. Hepatitis B vaccine is following an open vial policy. You can keep the same vial till it is over up to 30 days, as long as the cold chain is maintained and the expiry date is there. But in BCG, once you reconstitute, it should be used within 6 hours. That's the BCG syringe and the needle. You can see that the BCG syringe is a 1 ml, 0.1 ml syringe. So you must use a 0.1 ml syringe because the accuracy of the dose is very, very important. So you will use a BCG syringe to give BCG vaccine. And the needle is a short, narrow gauge needle with its 26 gauge and having only a 15 millimeter length of the needle. This will be used for administering the BCG vaccine. The dose in the newborn is 0.05 ml and the route is intradermal. A special type of syringe is also available in some places where you can have 0.05 ml syringe also. But what we have in our facility is 0.1 ml syringe. Please don't substitute as much as possible your insulin syringes for administering BCG vaccine, because you cannot administer the accurate dose of 0.5 ml. So use only a syringe that is designed for BCG administration. See how a BCG vaccine is administered. See, it's intradermal, into the skin. The needle, see how horizontally it is placed. Whereas the hepatitis B vaccine, you would have seen it's gone, the needle is going perpendicular. But with this intradermal vaccine, you could see that the syringe and the needle are horizontal, in plane with the skin, so that it facilitates that you enter only the skin and inject that 0.5 ml into the skin, and you can see a small wheel is being raised into the skin, and it is given at the deltoid, close to the insertion of the deltoid. See, after the vaccine is administered, you can see that wheel there, which is around 5 millimeter in size. So injecting 0.5 ml will raise a wheel about 5 millimeter, and that's how a successful BCG vaccine administration will be looking, because there is a danger and chances that when you are administering BCG, you need to be very careful, because even if it slips a little, it will go subcutaneous. If you go subcutaneous, you get a lot of complications. And so this BCG administration requires a little more skill and a little more patience in giving it intradermal. See here, this is a wrong side. This was done in one of the facility. You can see it's not in the deltoid, but given very low. This is wrong side. This is the wrong side for BCG vaccine. One need to choose the deltoid region close to the insertion of the deltoid. See this is also wrong side. See, this BCG vaccine is given high above the deltoid, very close to the shoulders. This should also not happen. So choosing the right side for the vaccine is very, very important. For BCG vaccine, you will choose the deltoid region, preferably the left hand, because for uniformity. Why the left hand? Because it's very easy to identify when children come whether they have given BCG vaccine. Instead of searching both the hands, just search for it in the left hand. And if you see in the left hand, you will know, you will see this, if the children are coming after 12 weeks, you can see the scar. So BCG vaccine is given in the left deltoid, and it is given intradermal, and the dose is 0.5 ml. Now, how does it evolve? And 2 or 3 important information when administering a BCG vaccine. Do not use any disinfectant to clean that area. Simply clean it with saline or sterile water and allow it to dry, and then start your injection, because your disinfectant or antiseptics that will inactivate the bacillus. You know, it's also a live vaccine, which is an attenuated vaccine, and you need to be careful at the time of administration also. See, the moment you administer, you get a wheel that I have shown you in the previous picture. Then after some time, after 2 weeks time, it changes into a papule like that with red color. And about 4 to 6 weeks time, it changes into a small fluctuant blistering abscess. Then it ulcerates, and then from the ulcer, you get exuding a small amount of pus. This exudation of pus may happen 2 or 3 times, and then heals, and then you will see a small puckered scar, very small size scar. And this is the natural course of BCG vaccination. So from the time of administration to around 12 weeks time, it takes for it to go through this entire reaction and form a scar. So we take it a good, a very efficiently administered, properly administered BCG vaccine, which has ended up in a very good scar, which means the child immune system would have definitely got stimulated for a better immunogenic response. Now we come to the third vaccine that is used in the birth dose vaccine, that is the oral polio vaccine. It's also a live vaccine. It is containing the live attenuated poliovirus derived from the wild polioviral strain by passage into non-human cells, especially the monkey kidney cells. And what we are using today from 2016, we have shifted to the bivalent polio, which means it contains only 2 strains, 1 and 3. So for BCG administration, I will complete that. When you should administer, normally administered on the next day of birth, but you can do it anytime after birth, and you have a time interval of up to 1 year to administer BCG vaccine. But you should not wait, because our community is endemic for poliomyelitis, for tuberculosis, and you should not take the risk of exposing the child. So protect them earlier. So prevent them from getting infected. So best thing is to administer this BCG vaccine even before they are discharged from the facility. And the other one is the oral polio vaccine. It's a live attenuated vaccine. We told you it's the bivalent 1 and 3. And that's the polio vaccine vials. And all of them will be supplied with a dropper or dispenser for ease of administration of the polio virus into the mouth. So it is transparent, sometimes, or yellowish orange or light pink colored solution. The reason for putting that, you don't get upset when you see a transparent one and next time you see a light pink color, because different manufacturers have are coming with different of these colors, because phenol red is added as a pH indicator. The once opened, the multi-dose vial should be kept between 2 to 8 degrees centigrade. And this also follows an open vial policy, which means after opening a new vial and you have started administering whatever remaining polio vaccine, you can keep them in your refrigerator at +2 to +3 centigrade and use it in the next session. You can keep them for up to 30 days, provided you maintain the cold chain and also have the vaccine vial monitor properly monitored. So it must be administered. The route of this vaccine is oral. So here is a oral vaccine. All you need to do is put the vaccine into the mouth. So how much drops? 2 drops is put. And I'll show you one picture how what care you need to take while putting this into the mouth. Usually it comes as a multi-dose vial, and you need a dropper or dispenser to administer the 2 drops. Care should be taken not to contaminate this dropper tip with the saliva of the vaccine, because we are following an open vial policy. We are going to store it back in the refrigerator. So you will do it with sterile hands and taking care to see that the dropper doesn't touch the baby's mouth. We also don't touch the dropper. Once opened, the multi-dose vials can be kept between +2 to +8, and it's an open vial policy. See that OPV administration. When you are administering the 2 drops, don't put it directly into the throat. See, that may sometimes cause choking sensation for the baby. All you need to do is drop the 2 drops on the tongue, or just below the tongue, because the child normally, every newborn has got this sucking and swallowing reflex. The moment you drop this, it will suck and swallow these 2 drops that is administered. Take care to see that you don't put it when making it cry and putting it deep into the throat, because there is a chance it may get this 2 drops may get aspirated. So this care should be taken while you are administering OPV. And one important thing is the vaccine vial monitor. One should see that the vaccine that we are administering is potent. How to know that the vaccine that we are administering is potent? Whether we have stored it in the proper temperature, whether any temperature outages in the current outages in the facility has made the storage at +2 to +8 degrees at default by just looking at the vaccine vial monitor. If you see the lighter area there, the first 2, you can use them. If the vaccine vial monitor changes color so that they become same, or the center becomes darker, which means those vials should not be used, because they would have lost their potency. So you should not use those vials for administering the oral polio. And this care should be taken every day when you are taking the polio vials from the refrigerator. Kindly check the refrigerator temperature to check the vaccine vial monitor before you start administering to the babies. And many questions comes whether they should be administered after feeding, before feeding. Feeding does not interfere with the polio drops, with the immunogenicity of the polio drop. Preferably, I would say, done before you start feeding the child, because if the child has fed its mother milk completely full stomach, And if you are dropping 2 drops, the child may have nausea and sometimes may vomit. So to avoid this phenomenon, its best thing is to put these 2 drops in the mouth, and then after an interval of 10 to 15 minutes, you can feed soon after also. But preferably after 10 to 15 minutes, you can ask the mother to feed the newborn very safely. So when we should give this OPV, normally is given anytime from birth. It can be given in the labor ward itself, or it should be given before discharge of the baby from the facility. And the 0 dose OPV, what we call, should be given from birth, and you have a maximum time limit, that is 14 days. Suppose you have missed the opportunity to give a oral polio vaccine within 14 days, don't give a oral polio vaccine beyond that period, calling it a 0 dose. A 0 dose means it should be given from birth to up to 14 days. Hepatitis B vaccine should be given from birth within 24 hours, or sometimes due to some reasons, if not being able to given within 24 hours, you must somehow plan it within 72 hours. And the BCG vaccine, preferably from birth, normally it's given on the 2nd day after birth. It preferably given before the baby is discharged from the facility. Giving vaccines like oral polio and BCG before the discharge of the baby will help us achieve a large coverage of these vaccines, because it's not easy for the mothers who have delivered a baby to go home and come back immediately for the vaccine. So they will have to recover from their all the pregnancies. So one needs to plan in such a way everyday immunization schedule in facilities wherever deliveries are taking place. It should be planned in such a way that the vaccine is made available to the baby, like BCG and OPV before discharge, and hepatitis B within 24 hours of birth. That's how the vaccine is stored. If you have a refrigerator, you must have a refrigerator in the delivery room. And see the compartment where hepatitis B is stored. It's in the middle compartment, and the OPV is kept in the upper compartment below the freezer. And the BCG is also kept in the compartment next to the freezer. So this is how the places in a refrigerator where we store vaccine, where the vaccines are used on a daily basis. This is not long-term storage. These are storage places where vaccines are kept for shorter duration, very close to the facility where administration of the vaccine is done. These are the places where you store them properly. Thank you all the participants. Make birth dose vaccine a successful one, because you know tuberculosis is rampant. Hepatitis B is dreadful, can cause cancer, and can cause chronic liver disease and shorten your lifespan and increase the morbidity. And we know OPV given soon after birth means you give the baby a chance for the virus to act very well and induce immunity in the child, so that the child doesn't get into the community and have a chance of getting a wild polio virus from the community. So plan BCG vaccine, BCG, hepatitis B, and 0 dose OPV, all these 3 vaccines which are called birth dose vaccination, and immunize every children and make them protected from these common diseases. Thank you very much.
Thank you, Dr. Harrison. It was indeed a very appealing and captivating presentation, engaging almost all the people who have been listening to this presentation on a very sensitive subject of the birth dose immunization. And it was very comprehensive and helping to enhance the skill of the frontline service providers. And thank you very much for this nice presentation, sir. It will definitely be very useful to all the people who have listened. Thank you very much.
Thank you, sir.
Thank you, Dr. Arasa, for such an amazing talk that you've given us today on birth dose immunization. So next, may I call upon Dr. Vijayalakshmi, Secretary of Ogssi, to talk on postnatal care.
Yeah.
Just a second.
And shall I introduce this topic? Okay. Yeah.
Yes, sir. I'll just share the screen.
Okay. Now I will, Dr. Vijayalakshmi, and she's going to talk about this antenatal care. And as with antenatal care, promoting a lifestyle she's going to talk about the postnatal care, of course. As with antenatal care, promoting a healthy lifestyle with good nutrition, detecting and preventing diseases, supporting women who may be experiencing intimate partner behavior and ensuring access to sexual and reproductive health, including postpartum family planning, are key to quality postnatal care. And the main purpose of providing optimal postnatal care is, of course, to avoid both maternal and neonatal death. As the roller coaster ride you hoped on come to an end after 9 months of antenatal period and also the tedious delivery process. There are miscellaneous things to be taken care of during after postnatal period, that is immediately after birth too. The first few hours and days after delivery are the riskiest for both mothers and newborn. That is why aftercare should be given to both mother and baby. Well, most of the focus more are on emergent pregnancy care on the first 9 months of pregnancy. Postnatal care or postpartum care should also require same care, that same attention that we are giving to the antenatal care. Over to Dr. Vijayalakshmi.
Dr. Vijayalakshmi Gnanasegaran is a gynecologist, obstetrician, and an infertility specialist. She has an experience of 26 years in these fields. She's completed her MBBS and MD of obstetrics and gynecology from Madras Medical College. She is a member of the Indian Medical Association, the Obstetric and Gynecology Society of Southern India, Indian Menopause Society, and the Federation of Obstetrician and Gynecology Society of India. Her area of interest is infertility evaluation, treatment on high-risk pregnancy care, and adolescent gynecology. Currently, she is the secretary of Ogssi. May I invite Dr. Vijayalakshmi ma'am to talk on postnatal care.
A very good evening to one and all. I thank Iyer sir for the very nice introduction about the postnatal care, and thank you, Meryl, for the kind words that you have said. And first of all, I would like to apologize for joining very late. Iyer sir, Arasar sir, and all other faculties who are here, I was stuck with an emergency, so I couldn't join on time. So thank you, Arasar sir, for adjusting and advancing your talk to before mine. And we will now go on shortly to the topic of postnatal care. As Iyer sir rightly mentioned, postnatal care is a very, very important part of obstetric care, which anybody should know. All the obstetrician, gynecologists, and the nurses, and whoever are the people who are involved in delivering should know about postpartum care and contraception. Essentially, since this is a talk for all the nurses who help in delivery, so I have kept this talk very, very simple so that all of you can understand it very well. I had actually planned for an interactive session, but unfortunately, due to technical issues, we are unable to. So I would like, at the end of this session, I would be happy if all of you could take home the definition for what is postpartum period. Sir, I am very clear, no? My voice is audible?
Yes, madam, you are clear, madam.
Thank you, sir. So I would like you all to know what to define the postpartum period, to evaluate and identify complications during this period, complications from simple ones to a little far-fetched or complicated ones, institute appropriate treatment to the mother and baby, have a knowledge about what is the treatment that is going to be given, provide basic health education to the mother and family, and as sir said, provide family planning services, which is very, very essential. So the maternal and infant care is the period of the transfer from intrapartum care until the end of the postnatal period. Usually up to 6 weeks, we call it as postpartum period. So the first 24 hours is very, very crucial. Then the next is the early postpartum period, which is up to the first 7 days. And the remote is from the 8th day up to the 6th week of postpartum after delivery. Is how we classify. So going on, once the patient is delivered and she is there in the postnatal ward, how are we going to approach? So in this initial first 24 hours, which is very critical, I'm not touching much upon it. What is important is, we are all the dreaded complication of postpartum is the postpartum hemorrhage. So immediately after the delivery of placenta, the hemorrhage might take place, or it may happen a few hours afterwards also. That is why immediately after delivery also an observation period for at least up to 2 hours is very essential in case of a normal delivery, and extended period for the operative deliveries. During that time, the main risk factor is postpartum hemorrhage, which all of us should be aware of. And that becomes part of the intranatal care or management of third stage of labor, the same way we're going to manage. Now, we are going to talk about a woman who has delivered, who is safe, and she is back in the postnatal ward. So the immediate complications and all have not been there. Now she is there in the postnatal ward, and you are going to see her. So most of the care which is provided, see, doctors are important for making the treatment, but essentially the care for any patient, whether it is medicine, surgery, OG, peds, whatever, the care is from the nurses. So you are the most compassionate person who really talks to them, spends more time with them. When we go for rounds, we have hardly 10 minutes, 15 minutes, we spend time with the patient. Unless it's critically ill and we have to spend more time, we generally do a overall talk and we leave. But it is you who are there for hours together, 6 hours, 8 hours, there with the patient during a shift. And it is you who will be able to pick up even the slightest of problems that she may have. So the empathy towards the patient, the consideration and care is basically the thing, qualification of a nurse. So the first question that you should be asking is, how are you feeling? So she may be depressed. She may be having so much of pain in her. So all that the only person whom she can express is would be you. So ask in general, how do you feel? Do you have any pain? Are you having fever? Is there any excessive bleeding per vagina? You would be examining, but first ask her. Ask her regarding problems with passing urine. Because of the pain, the perineal region, episiotomy would have been given. There may be some injury to the perineal region, so a lot of stitches would have been done. So she may not be able to pass urine freely. So only you have to ask her and elicit whether she has passed urine and whether she is comfortable or not. And generally through an open question, do you have any other concerns? Then she will tell. So sometimes only when we open questions when we leave, they will be able to tell us better than just asking them tell questions which says yes or no for an answer. Then you can ask them, how do the breasts feel? So she's especially in a primiparous woman. This is the first time she's giving her breast milk. Okay, breastfeeding. It is new for her. For all babies, whether it is a prime's baby or whether it's a Maltese baby, for the baby, the breast is new. For the first delivery, the mother, the breast is new. So she may have so many issues with the breast, which she wouldn't know who to ask. Maybe her mother, and her other attendants, lady attendants might help her. But it is you who can pick it up. Ask her how the baby is. Is there any problem with the baby? If she feels anything is abnormal. So you can communicate it better to the pediatrician. And then the important question is to ask regarding the contraception. Have you decided? So the question about contraception and advice about contraception would have been thrown in the antenatal period itself. But you have to ask her regarding the contraception in the postnatal period if it was not already given. Then once you have talked to her, then look for certain things. So what are the things that we generally look for? Look for pallor. So look at the tongue. Ask her to put out the tongue. See whether it is pale or whether it is pink. You can look for pallor in the conjunctiva, palpebral conjunctiva you will look. So hands, probably we can use palms of the hands. In babies, of course, soles, but in adults we cannot use. So tongue would be the main thing, tongue and the conjunctiva. So look for also glossitis in the tongue. That is also another thing which you can pick up. We might have missed it in the earlier. So vitamin deficiencies can be picked up from this glossitis. Then you can look for angular stomatitis. So these are all the things which we can look for. Then also look for swelling in the legs. So pedal edema, which you would have had in the antenatal period. Now the edema sometimes postnatally, because of all the fluid recirculation, edema might be more. And mostly because of lying down also the edema may be more. Or the edema may be because of hypertension which she has developed. She might have already been a hypertensive or may not be an hypertensive in the past. But during the postnatal period, for the first time, she might have been developing edema and hypertension. So look for swelling in the legs. So mainly pedal edema, we are concentrating on about the pedal edema. But tenderness in the leg, in the calf muscle, so elicit for tenderness in that region. So it's a very, very important sign. We will see for what we are going to ask for. Then routinely, all of you take the temperature, pulse, and blood pressure. See, on the definitely for a person who is a normal delivery with no risk, low risk factors, at least once in the postnatal period, first time at least, you must record the blood pressure and pulse once at least every day. So get into the habit because it has always been normal. Just like that, don't write it. So BP may be elevated for the first time in the postnatal period. So always recorded the blood pressure, the temperature, and the pulse. And nowadays, with this COVID era, it has become mandatory to record the oxygen saturation of also of everybody. Then feel for the uterus. The abdomen examination can be done by you all. Need not wait for the consultant to come and do. So whether they are doing or not, they will be doing, but you also do it once. The uterus will be very hard. Every consistency is described as cricket ball. ஒரு cricket ball தொட்டா எவ்வளவு ஹார்டா இருக்குமோ that kind of a hardness should be there. So look for that hard and round uterus. And where is the level of uterus? Umbilicusக்கு கீழ இருக்கணும். So that is where it is the uterus should be present. If the uterus is not hard, it is a little soft. That means the uterine contraction is not good. So she may develop a postpartum hemorrhage, bleeding ஏற்படலாம். So you must look for the uterine, the hardness of the uterus. Look for vaginal bleeding, excessive bleeding ஏதாவது இருக்கா or normal periods தானான்றது you must always look for. Meryl, if I use Tamil in between, is it okay or should I speak only in English?
No, ma'am, it's fine.
Tamil would be good because there are a lot of other community volunteers would also be listening through YouTube. So it would be
Okay.
good to know.
Okay, fine. So look for vaginal bleeding. So bleeding எவ்வளவு இருக்கு? Normal periods விட definitely it will be more. Is it more or is it too much of bleeding? Clots இருக்குதா? Bleeding அதிகமா இருக்கா? So number of pads are more. So even before the doctor comes for rounds, you can alert the duty doctor. Excessive bleeding இருக்கு doctor, உடனடியா பாருங்க. So that you are the first person. Always remember, you are the best person to pick up any complication. Then look at the perineum. And the perineal region நிறைய tears இருக்கும், cut இருக்கும், suture பண்ணிருப்பாங்க, episiotomy suture இருக்கலாம். So whether it is all looking healthy or is there any extra cut there which is not sutured, and how is it on the second or third day la பார்க்கும்போது every day you must look at the episiotomy. A little delayed infection can happen. Then that episiotomy area will be red and swollen. And sometimes there may be pus. But nowadays, with the advent of antibiotics, we don't see so much of pus. But still, it is our duty to look at it. Sometimes episiotomy gape irukkalam, infection nala. So only you will be able to pick up the gaping in the episiotomy. So you have to look at all these things. So these are the examination findings which you should remember. Now you have looked at and you have picked up anemia. This is very, very common in our community. So anemia, like how sir said, tuberculosis was the common pediatrics. In our community, we should never forget tuberculosis. In our society, we should never forget anemia. It is one of the common things. Antenatal and postnatal also. Antenatal anemia little bit of blood loss during labor could cause anemia in the postnatal period. So treating anemia is very, very important. Anemia is only a sign. Anemia is a disease. It's only a sign. But if you leave anemia, it will lead to a lot of problems. Feeding பண்ண முடியாது, the lactational failure will be there. Uterus will have infection. Subinvolution of the uterus will happen. And very severe anemia போச்சுனா cardiac problems வரலாம். So anemia is a very important thing which you should look for. And for your level, definitely medication. Suppose anemic இருந்து pick up பண்றீங்கன்னா, you can put forward to the doctor. Otherwise, advice regarding diet. So everybody would have had some amount of blood loss or the other. So diet rich in iron is definitely a must for all postnatal women. So enna madri diet சாப்பிட சொல்லுவோம்? Non-vegetarian இருந்தா you can tell them eat lot of meat and liver, especially you can tell them to eat fish விட meat and liver is important non-vegetarian sources. Vegetarian sources vegetables are not a good source of iron, but green leafy vegetables பச்சையா இருக்கக்கூடிய காய்கறிகள். So all your greens, முருங்கைக்கீரை, அகத்திக்கீரை, கறிவேப்பிலை, புதினா, பேரிச்சம்பழம், okay, vellam, jaggery has high iron content. So in the antenatal period as well as postnatal period, diet on iron should be taken. That you have to advise. Jaggery. அதே மாதிரி கால்சியம் சப்ளிமெண்டேஷனுக்கு ராகி. ஸோ அதனாலதான் நம்ம கவர்மெண்ட்னுடைய இதுல ராகியும் வெல்லமும் சேர்ந்து உருண்டை பண்ணி நம்ம கொடுக்கறதுக்கு காரணமே யூஆர் கிவிங் அயர்ன் அண்ட் கால்சியம். ஸோ நான் உங்களுக்கு நிறைய பேருக்கு இதெல்லாம் தெரிஞ்சதா இருக்கலாம், பட் இட் மே பி a repetition, but still these are important things which people should take. So dietary advice நீங்க you have to give. Then if she is anemic, There are different forms of iron therapy. Depending on the hemoglobin level, the doctor might decide to give oral iron tablets. So ferrous sulfate tablet or carbonyl iron tablets are available. Or the doctor may decide to give IV iron, iron dextran, iron sucrose if it is available. So antenatal period as well as postnatal period we're giving iron sucrose. Rumba severe anemia varda, the patient may need blood transfusion. That let the doctor decide. Then this is the other thing. I told you like calf muscle and the kanukal அப்படின்னு சொல்ற இடத்துல அதிகமான tenderness, pain, and when you touch that area there is severe tenderness. So that is where this is the most important thing which you should elicit. So this is means we are diagnosing a condition called thrombosis. Blood vessels, veins, there is blood clotting has happened. Thrombosis of the blood veins. So this will lead to superficial veins, then it will become deep vein thrombosis. Then it develops a condition called as phlegmasia alba, phlegmasia cerulea. Alba na white color ஆயிடுது காலு, cerulea na blue color ஆயிடுமா காலு. So இது வந்து alba-வா, this thing leg is supposed to be white in color, இந்த இடத்துல எல்லாம் white இருக்குது. So if you take the thing, you see bluish discoloration வந்துருச்சு. பட் இதெல்லாம் வந்து ஃபாரின் கண்ட்ரீஸ்ல டிஸ்கிரைப் பண்ணாங்க, வெள்ளையா இருக்கு ப்ளூவா இருக்கு, நம்ம கலர் வந்து வெள்ளையா இருக்கு, he can find out. Whereas in our color we may not be able to find out in this kind of a difference. But swelling, so in the இடத்துல இந்த calf muscle swelling இருக்கா and acute tenderness ஏதாவது இருக்கா, patient complaints of pain அப்படின்றதா இருக்கா அப்படிங்கறத பார்க்கலாம். And initially when you touch the limb, காலை தொட்டா வந்து வார்மா இருக்கும். So that is what you can find out. And if the coloration தெரியுது, bluish discoloration, இன்னும் ரொம்ப severe conditionக்கு போய்கிட்டு இருக்குதுன்னு அர்த்தம். If we leave it, sometimes the entire leg gangrene வரைக்கும் போயிடலாம். And this kind of a clotting, இங்க இருக்கிற clots can travel all the way to the heart, and from the heart to the lungs போயிட்டு pulmonary embolism வந்து it can even lead to the death of the individual. And arteries க்கு போயிடுச்சுன்னா it will cause arterial occlusion, ischemia and gangrene. So blackish discoloration க்கு போயிட்டு gangrenous வந்து மாறிடலாம். So clinical diagnosis is very, very important. So inspection, look at the legs. So leg வந்து reddish இருக்கா, swollen இருக்கா, pain இருக்கா, all that you have to see. And then elicit signs called Homan's sign and Pratt's sign வாங்க. Homan's na nothing, இந்த calf muscle பிடிச்சு நம்ம கொஞ்சம் லேசான pressure கொடுத்தோம்னா acute pain இருக்கும். Another thing is, if this in the ankle கிட்ட நம்ம வந்துட்டு ankle just இப்படி வளச்சாப்ல பிடிச்சு பார்த்தோம்னா they will complain of severe pain here. So that kind of signs are the Homan's sign and Pratt's sign. So this means the patient is developing deep vein thrombosis. So அந்த மாதிரி patients க்கு different types of treatment, analgesics, leg elevation and anticoagulation, heparin போட்டு anticoagulation கொடுக்க வேண்டியிருக்கலாம், or low molecular weight heparins may have to be used. So the drug therapy the doctors will decide. But why I said this is very, very important is, from there that embolus can travel all the way to the lungs and cause pulmonary embolism. So pulmonary embolism vandadina we will lose the patient. So that is one thing which we should prevent. So deep vein thrombosis is very, very important. Another thing is fever. This we can easily pick up. Patient temperature or you can be recording the temperature. So temperature has to be recorded at least twice in the first 10 days after delivery to find out whether she has puerperal fever. The puerperal fever, what are the various causes? So infection, fever is a sign. That means there is infection somewhere. It can be in the uterus or it can be breast. So she is breastfeeding. Proper breastfeeding illama paal kattikittu irundaduna and kattitu irukra paal nalla breast abscess breast infection varala. Mastitis, breast abscess adanala. Uterus infection வரலாம், urinary or just simple நம்ம போட்டுக்கிற stitches, episiotomy stitches infection வரலாம். But infection in the uterus க்கு போனாதான் it will cause puerperal fever. Urinary infection இருக்கலாம், thrombophlebitis நம்ம பார்த்தோம்ல blood clotting, from there thrombophlebitis. Phlebitis na infection of the entire vein, அப்படியே ஃபுல்லா infected ஆயிடுச்சு, inflamed ஆயிடுச்சு, அதனால there is fever. Or other causes, other incidental, and the patient malaria வரலாம், dengue வரலாம், வேற ஏதாவது காரணமா கூட இருக்கலாம் ஃபீவருக்கு. So what are the causes of puerperal fever அப்படிங்கறத பார்க்கணும். So then as I said in the beginning, life threatening complication என்னன்னா postpartum hemorrhage. Within the first 24 hours குள்ளே உங்களுக்கு bleeding வரலாம். First few hoursல வந்துச்சுன்னா atonic postpartum hemorrhage, immediate treatment தேவைப்படலாம். And then later on வந்துச்சுன்னா it is called secondary hemorrhage. That 48 hours க்கு மேல, then sometimes she will develop bleeding, or even 7 days this kind of a bleeding can happen. That is called secondary postpartum hemorrhage. Usually uterus kulla infection, or there is some placental bit which is left inside the uterus and that got infected and that is bleeding. So andamari there is some infection which is leading to bleeding. So secondary postpartum hemorrhage. ஒரு வாரம் நல்லா இருக்காங்க, திடீர்னு கொட blood கொட்டுது. That is secondary postpartum hemorrhage. அதே மாதிரி pre-eclampsia, eclampsia. In the postpartum antenatal period full BP was normal, but suddenly postnatal period she can develop pre-eclampsia. That is why the recording blood pressure is very, very important. And eclampsia, sudden fits throw pannittu varalam. The sudden fits adicha, it may be because of eclampsia, or it can be due to another condition called cortical venous thrombosis. So postnatal delivery aanavungalukku all these can happen. These are all life threatening conditions. Another thing which we should never forget, neenga da idu kandupidikkum, emotional well being. Delivery ஆனதுக்கு அப்புறமே சில பேருக்கு நீங்களே நிறைய பேர் பார்த்திருப்பீங்க, சிம்பிள் சின்ன விஷயமா இருக்கும், suddenly they'll get very upset and start crying. பெரிய விஷயம் கூட they will manage, but small things they will become upset. What we call as postpartum blues, அதே கொஞ்சம் சிவியரா போனா postpartum depression, இந்த மாதிரி words எல்லாம். So all these can happen during the postpartum period. These are minor ailments. So minor things என்னது, uterus contract ஆகுது, normal delivery க்கு அப்புறம் normal size க்கு வராது இல்லையா, it will be almost up to just below the level of umbilicus. அதுல இருந்து it will keep contracting to come down to the normal size. அப்படி வரும்போது அதுக்கு you can develop what is known as after pains. Sometimes urinary retention, pain at the perineal site, breast engorgement, mastitis, so inflammation of the breast, sore nipples. So feed பண்ற technique you must teach them. So feeding the child technique சொல்லி கொடுக்கிறது is important. வெறும் nipple மட்டும் வச்சு they should not feed. This entire areola, what is this black round around the nipple, should be used for feeding. That is called latching. And the proper latching இல்லைன்னா nipples நுடைய வந்து crack ஆயிடுது. அந்த cracked nippleனால sore nipples, மார்பு காம்பு வெடிச்சு போய் புண்ணோட வர்றாங்க. That may lead to mastitis and breast abscess. Then urinary problems which we already said. So these are all problems which you can identify. So how do you manage all normal mothers? So abnormalities இருக்கான்னு கண்டுபிடிக்க வேண்டியது உங்களுடைய வேலை, நீங்க அதை செய்யணும். Then how do you manage a normal mother? எந்த ப்ராப்ளமும் இல்லை. So advise her to avoid strenuous activity for 6 weeks. At least 8 to 10 hours ஆகுது அவங்களுடைய தூக்கம் இருக்கும். தூக்கம்ன்றது வந்து need not be nightல தான் தூங்குறது. Whenever the baby sleeps, she should also take adequate rest and sleep. It may be in the morning or it may be in the day, midnight, whatever depends on the baby. Early ambulation, ரொம்ப நேரம் படுத்துட்டே இருப்பாங்க, எழுந்துக்கவே மாட்டாங்க. They don't even get up to brush their teeth because of the severe pain. You should encourage them and make them get up. Otherwise they'll develop cortical venous deep vein thrombosis வந்துரும் கால்ல. So dietary thing you have to advise. Take care of the episiotomy stitches and care for the nipple and areola. So examine பண்ணணும். Also advise பண்றது, care and hygiene பத்தி advise பண்ணணும். Washing the perineal region வந்து தண்ணி, general advice பக்கத்துல இருக்கவங்க சொல்லுவாங்க, வீட்ல இருக்கவங்க சொல்லுவாங்க, தண்ணி போட்டு கழுவாத, சீழ் புடிச்சுக்கோ அப்படின்னு. You have to advise them that washing only will prevent infection, prevent pus, prevent சீழ். கழுவுனாதான் சீழ் பிடிக்காது, இல்லைன்னா அந்த மோஷன் வந்து anal region is very close to the vagina. So any of the anal particles, நம்ம motion போற particles போய் episiotomyல உட்கார்ந்துச்சுன்னா definitely infection will be there, and that infection will be ascending up into the uterus. Uterine infection and sepsis க்கு போயிடும். So keeping yourself clean and hygiene is very important. சொல்லி தரணும். Nutrition பத்தி you have to teach them, and counsel on birth spacing and family planning. Already they have decided இல்லையா, அப்படி இல்லைன்னா now is the time to advise them. Iron calcium supplementation and advise them on when to review next. So importance of washing, இதெல்லாம் hands before handling the baby, wash perineum twice daily, and after ஒரு தடவை urine motion போனா the area has to be washed with water. No need to apply all chemicals like Dettol போட்டு கழுவலாம் சொல்லி தராதீங்க. They should not use any kind of chemicals like that. Washing with just water is very, very enough. And taking bath every day. And changing pads, ரொம்ப நேரம் சோக்காக விடக்கூடாது. And avoid sexual intercourse till perineal wounds. இதுல நிறைய பேர் பேசக்கூட மாட்டாங்க sexual intercourse. அவங்க யாரை போய் கேட்பாங்க? We are the only people whom we can advise. So avoid sexual intercourse till the perineal wound heals. We have to teach them. நாமளா முதல்ல சொல்லிடணும். So healthy food, extra 300 calories, lot of cereals, proteins, vitamins, milk intake, dietary இதெல்லாமே ஃபுல்லா வந்து we have to teach them. So their diet should be a balanced diet, rich in proteins and carbohydrates, fats வந்து குறைச்சு சாப்பிடுங்கன்னு சொல்லணும், and liquid diet வந்து நிறைய எடுத்துக்கணும். And now that they are feeding the baby, they should be taking lot of soups, juices, அந்த மாதிரி liquid items கஞ்சி எல்லாம் before feeding ஒரு நல்ல ஒரு liquid item அவங்க குடிச்சிருந்தாங்கன்னா feeding would be really good. So spacing out 3 main meals இல்லாம space it into smaller meals over the dayன்றத சொல்லி தரணும். And it is not only teaching the mother who is very important na avங்களோட partner, avங்களோட mother and especially the mother-in-law. If the mother-in-law is there, you have to keep them as a family and teach them. மொத்தமா சேர்த்து வச்சு அவங்களுக்கு கிளாஸ் எடுக்கணும். நீங்க ஒரு பேஷண்ட்டுக்கும் அவங்க ஃபேமிலியோட சேர்ந்து வச்சு you have to teach them. Otherwise there is a lot of food taboos. இது சாப்பிடாத, அது சாப்பிடாத, இதை சாப்பிட்டா பாப்பாக்கு ஆகாது, மந்தம், வாந்தி வரும், அது வரும் சொல்லுவாங்க. So you have to teach them what are all the food that they can take அப்படிங்கறத சொல்லி தரணும். Encouraging her to eat and adequate rest வேணும்ன்றதையும் you have to tell. So next we come to the most important thing, which is postpartum contraception. So contraception, kudumba kattupaadu, has to be practiced for. It can be temporary or it can be permanent. She has completed the family, 2 children already aiduche. Then we can advise regarding permanent contraception. Suppose it is 1 child and a birth spacing kaga we have to advise contraception. So postpartum contraception na enna, it's the initiation and use of family planning method. Within the first 6 weeks itself, we start them to initiate. That is postpartum contraception. Okay, which is immediate postpartum within first 48 hours itself. Post placental within 10 minutes, delivery 10 minutes you are going to put a copper T inside. That is called post placental insertion. So postpartum period, I already told you, 6 weeks. In the 6 weeks then it becomes interval period or post puerperal period. Puerperium is the first 6 weeks. Adukulla pannamna postpartum contraception. Beyond that, interval period contraception. And contraception is not only for post-abortion. We should not forget post-abortion, postnatal mothers mattolla. Post-abortal mothers ko contraception vedum. So immediately if they become pregnant again, subsequent chances of abortions may be more. Okay, so we have to allow her to recuperate her health. And what is the cause of abortion? Evaluate pandradhukku we need some time. So for them also, post contraception has to be advised. அவங்களுக்கு வந்து abort ஆயிடுச்சுன்னா within the period of 2 weeks they can become fertile, they can become pregnant again. So அவங்களுக்கும் we have to advise them regarding contraception. So postpartum infertility, இப்போ delivery ஆயிடுச்சு, after delivery that itself provides contraception அப்படின்னு சொல்லிட்டு there is definitely. So most non-lactating women, அதாவது பால் கொடுக்கல அப்படின்னா within 4 to 6 weeks of delivery they will develop the menstruation and they will develop ovulation and they can become pregnant. So feeding the mother, feeding women are the lactating mothers na definitely their ovulation period is prolonged. So avangalukku vandu lactation itself can be a very important way of contraception, which we will look at now. So immediately after delivery the risk of pregnancy increases as the breastfeeding decreases and as time passes it will decrease. So first 3 weeks edutittinga breastfeed பண்ணலன்னா your risk of pregnancy is here in 3 weeks itself. நீங்க நல்லா feed பண்றீங்க completely அப்படினு சொல்லி சொன்னா 6 months, this is this picture, only breastfeed மட்டும் கொடுக்குறீங்க, வேற எந்த feed இல்லையா, 6 months வரைக்கும் contraception கிடைக்கும். But if you are only partially breastfeeding, 6 weeks தான் உங்களுக்கு protection இருக்கு, first 6 weeks, then you can become pregnant. This is something which even they may not have got the menses, but still pregnancy can happen. So this is what we have to advise them. If you're not breastfeeding, within 3 weeks you can become pregnant. If you're partially breastfeeding, within 6 weeks you can become pregnant. If you're fully breastfeeding, within 6 months you can become pregnant. So the WHO, recommendations are after a live birth at least 24 months, 2 years we have to give the minimum time before the next pregnancy. And after miscarriage or an abortion, at least 6 months has to be given அப்படிங்கிறது தான் advice. So family planning service counseling, when we should start அப்படின்னா, you have for when we should start the counseling and for whom we should start, கண்டிப்பா the woman will be willing for a family planning. ஆனா யார் you have to counsel her along with the partner or other family member like her in-laws யாராவது கூட வச்சுட்டு you must counsel. When you should counsel about this family planning method na, antenatal period the counseling should start, not after delivery. So the importance of spacing, importance of various methods available have to be explained, and counseling about safe sex for dual protection like barrier condoms use பண்றது பத்தி நம்ம we have to give them advice. Okay, so that has to be done. So the goal of postpartum or post-abortal counseling என்னன்னா, It should help each woman to decide if she wants contraceptive method. Contraceptive method venuma? Yes. To help her choose an appropriate method. These are all the various methods. So hotel ku pona idli dosa vada pongal puri eppadi solrom enna irukku server ketta he lists out. அந்த மாதிரி தான் contraception is always called a cafeteria approach. என்னென்ன இருக்கு? oral pills இருக்கு, hormonal injections இருக்கு, copper T இருக்கு, barriers இருக்கு, வரிசையா you have to tell them these are all the things that are available. So appropriate அவங்க எது choose பண்ணனும்ங்கறது நம்ம அவங்களுக்கு ஹெல்ப் பண்ணனும். And this counseling should happen during the antenatal period itself. So you have to, the contraception should be highly effective, protect against STD, prolonged duration of action irukano. And once they stop and they want to become pregnant, rapidly reversible, easy accessibility with minimal side effects irukano madri. And a contraception is what everybody would like to have. So this is what are the postpartum methods. So இப்போ some general guidelines. இப்போ யாருக்கு என்னென்ன postpartum methods நம்ம யூஸ் பண்ணலாம்? Okay, so you have to, whatever are the thing contraception you should advise என்னவா இருந்தாலும், the first thing what you should advise is எந்த contraception யூஸ் பண்ணாலும் it should not hamper breastfeeding. So healthcare providers should encourage complete breastfeeding for all women. இத ஸ்டாப் பண்ற மாதிரி ஒரு contraception நம்ம அட்வைஸ் பண்ணவே கூடாது. So breastfeeding should not be discontinued to start the use of a contraceptive method, and chosen method must not affect breastfeeding. So தாய்ப்பால் கொடுக்கறத தடுக்கிற மாதிரி எந்த ஒரு contraceptive methodsயும் நம்ம யூஸ் பண்ணக்கூடாது. And the advice should be to advise her to give the breastfeeding. So what are the various methods that are used? So all non-hormonal methods. இப்போ breastfeeding மதருக்கு என்ன கொடுக்க கூடாதுன்னா ஹார்மோன்ஸ் கொடுக்க கூடாது. So oral contraceptive pills orally எடுத்துக்கக்கூடிய combined மாலா N மாலா D மாதிரி pills கொடுக்க முடியாது. So other than that, non-hormonal methods எதுவா இருந்தாலும் it can be safely used in a breastfeeding woman. What are the non-hormonal methods? Na LAM னு சொல்றோம், lactation amenorrhea, condoms, male female condoms, spermicide, diaphragm, IUCD, copper T போடுற மாதிரி, or completed family அப்படின்னா permanent sterilization for both the male and the female. So these are all the various non-hormonal contraceptive methods. அப்படி இல்ல better method என்ன, எனக்கு pills தான் வேணும் அப்படின்னா alternative is progesterone only pills available இருக்கு, POPs, that can be given. And injectables, இதுவும் வெறும் progesterone மட்டும் தான் இருக்கு. இதுதான் அந்தாரா அப்படின்னு சொல்லிட்டு இப்போ government supplies available. So injectable contraceptives can be given. So least preferred use பண்ணக்கூடாதது அப்படின்றது என்னன்னா combined pills. At least for 6 months of breastfeeding வரைக்கும் நம்ம இது வந்து யூஸ் பண்ணக்கூடாது. So that is how you have to plan the contraception. So LAM method the best. First 6 months complete breastfeeding. Complete breastfeeding na என்னன்னா you have to continuously breastfeed. Alternate feeds எதுவுமே கொடுக்க கூடாது, not even water. And the baby should suckle எப்படின்னா 6 times in a day. And at night also it should get up for night time feeds. இந்த மாதிரி if you are feeding, that itself gives you contraception for 6 months. So it offers advantage for mother as well as the baby. No side effects at all, but effective only for 6 months. 6 months கழிச்சு ovulation can happen. Even இதே மாதிரி continuously feed பண்ணா கூட, then 6 months we have to give her contraception. The next one is copper T. IUD can be safely inserted immediately after the delivery of placenta. Post placental 10 minutes la IUD உள்ள போட்டு விட்டுறலாம், or within the first 48 hours குள்ள போட்டுடலாம். If the insertion does not take place within 48 hours, better to wait for 4 weeks. அடுத்து 4 weeks வரைக்கும் வெயிட் பண்ணணும். You cannot put it in between. And copper T normal delivery la தான் போடணும்னா இல்ல, even during cesarean section, post cesarean you can put in a copper T for the woman. So immediate postpartum IUCD is a very good option because of convenience and integration of services. It saves time. திரும்ப ஒரு repeat visit வந்த பிறகு contraception பத்தி பேச வேணாம். வராமே போயிட்டாங்கன்னா we will lose the chance. So one time insertion for longer use, 5 years, 10 years வரைக்கும் we can use. So postpartum IUCD is the best thing for contraception. And different forms, 380A 10 years இருக்குது, 375, 250 companies things are also available for 5 years and 3 years. And this is progesterone IUCD. சில பேருக்கு already menorrhagia, over bleeding இருக்கு அப்படின்றவங்களா இருந்தா progesterone IUCD can be given. But the best thing is here, IUCD is very, very effective. 99% effectiveness இருக்கு and no hormonal side effects, and it is a one-time procedure. So definitely it is beneficial. So எப்ப போடுறோம்? Postpartum, immediately after delivery IUCD போடலாம். But what are the contraindications? யாருக்கு we could not put? இந்த மாதிரி IUCD போடுறது தான் WHO recommendation. PPIUCD insertion அப்படின்னு சொல்றோம். So the consent has to be obtained in the antenatal period itself. Consent வாங்கிட்டோம், but இந்த conditions எல்லாம் இருந்தா we cannot put. திடீர்னு பேஷண்ட்டுக்கு excessive bleeding இருக்கு, unresolved hemorrhage, you cannot put IUCD. You are suspecting infection, chorioamnionitis in the immediate postpartum period itself, you cannot put IUCD. Rupture membrane, வெளியிலேயே membrane rupture ஆகி வர்றாங்க, more than 18 hours 20 hours அப்புறம் தான் ஹாஸ்பிட்டலுக்கே வந்திருக்காங்க, அவங்க டெலிவரி அப்புறம் தான் ஆகுது, we cannot put IUCD. Or any purulent discharge அந்த மாதிரிலாம் இருந்தாலும் we cannot put IUCD. So IUCD is a very safe method, but it has got very limited. I mean, there are a few contraindications for IUCD also. Okay. So postpartum IUCD is the one of the things which you can do. So IUCD can be inserted right after birth, post placental, within 10 minutes, normal delivery and cesarean. Soon after birth, immediate postpartum, less than 48 hours la nama போட்டுடலாம். During cesarean, அப்படி நீங்க 48 hours ல போடலன்னா you have to put it after 4 weeks only. 4 weeks கழிச்சு அவங்களை 1 month கழிச்சு வர சொல்லி நீங்க போடணும். As I already said, counseling எப்ப பண்ணுவோம்? Antenatal period. இல்லையா early laborல இருக்காங்களா, you can counsel at that time. Okay. But delivery boardல delivery ஆகிற நேரத்துல you should not counsel for IUCD insertion and put an IUCD. That is very wrong. And counseling வந்து should be for the client, for the husband and for the family. So counseling is a very important part of IUCD insertion. And on the antenatal case sheet you will be having this kind of the seal with postpartum family planning counseling has been done in irundana, we will go ahead and put in the IUCD. So verify, look for all these contraindications illiyan parunga. So under very strict aseptic precaution, after the delivery of placenta, active management vijaya ma'am solli kuduthirpanga. Amstel ku appuram you the contraindications la illana PPIUCD is done using manual or previously manual, but now it is instrumental. இது ஒரு நல்ல ஒரு நல்ல instrument Kelly's அப்படின்ட்டு. So you can catch hold of the IUCD, directly go inside and insert. So manual insertion is very very effective. So area வந்து நல்லா clean and sterile ஆக்கிட்டு with holding with the speculum and clean that area nicely. And aseptic technique noted above, you see the IUCD will be held in the இடத்துல இந்த limbல தான் போய் பிடிப்போம், but it should be held on the edge of the ring forceps so that it is easily released from the instrument. இந்த வேற எங்கயாவது இந்த இடத்துல எல்லாம் புடிச்சிட்டா it will be difficult to release. இந்த இடத்துல புடிச்சிட்டு ஈஸியா ரிலீஸ் பண்ணிட்டு வெளியில வர முடியும். Inside the sterile package in a sterile way தான் it has to be held. And இது uterus வந்து நல்லா stretch பண்ணி elongate பண்ணி புடிச்சிட்டு you just go inside directly. Okay, and your hand is there, you know where the fundus is, go up to there. Once you reach, just come down a little below, insert, keep the IUCD open. When you open this ring, you can leave the IUCD in position. The open away அப்படியே இத lateral sweep பண்ணி இந்த instrument எடுத்துட்டு just come down like this and remove the instrument. Okay, see how laterally this it is swinged and then it is brought outside. வெளியில வரும்போது close பண்ணிட கூடாது. If you close, you may accidentally hold the string and pull it down. So that is one thing, and you can conveniently advise breastfeeding after that. So this is immediately after delivery or within 48 hours postnatal ward la neenga vechi insert pannalam, or intracesarean also. Cesarean la panna pare thread ulla thalla mattanga, it will automatically come down. Then postnatal la when they come, where the thread is very long, it can be cut at that time. Okay, so post insertion technique la hospital entry alone has to be made, and routine postpartum care and ask them at a review we can see. So IUCD put routine, when will you ask a woman to come back for checkup? After 4 weeks. Or if there is any problem, fever, where abdominal pain, excessive bleeding, you will have to come and report immediately. We will advise. So this is how the IUCD is inserted. Other than IUCD, the other thing available is progesterone contraceptives and so on. Orally progesterone only pills are also available, and you can use injectables. Antara is the progesterone injection, which is depo-metroxyprogesterone, available as government supply. Combined pills, la Mala N, Mala D, and other trade names are also available in the market. So these should not be used because it decreases breast milk production, and also it causes breast milk or something happens to the baby, IUDs, you cannot breastfeed. Contraception for 6 weeks at least you cannot give, because now it will cause a lot of thromboembolism, blood clotting promote pandrathnala you should not use the contraceptive method. Permanent sterilization, if they have completed their family within the first 48 hours, it is better to perform it. and within up to 7 days வரைக்கும் WHO allows us to perform. 7 days குள்ள பண்ணலன்னா then 6 weeks வரைக்கும் we have to wait. Non breastfeeding இருந்தாலும் same things can be used. Okay, so IUCD can be put in, or you can use Antara, you can use IUD, you can use after 6 weeks கழிச்சு இவங்களுக்கு வந்து 6 weeks கழிச்சு oral pills கொடுக்கலாம். non breastfeeding இருந்தா, breastfeeding இருந்தா 6 months வரைக்கும் நம்ம oral pills கொடுக்க மாட்டோம். So these are the family planning thing. So summary is, it's a variety of family planning methods that are available. LAM, hormonal method, hormonal progesterone only method, IUCD, condoms, permanent method like tubectomy. So postpartum woman la consideration, return to fertility appo venu, when you can resume intercourse advice, use of LAM method, encourage them to breastfeed, and start postpartum counseling early in the antenatal period itself, and multiple opportunities every month kadaikum. So you can continue the counseling and make it a part of your routine care, and you can give the postpartum counseling at that time. So what are the quiz what I have already mentioned only is in this. That's all. So all women postnatal, we will review within the first 1 week or visit vara solvom. Adukapra 4 to 6 weeks we can follow up. Hypertension irukra women are the frequent follow up. 1 week kulla varanum. Moderate anemia 4 weeks la nama paathupodu. Within 2 weeks, if they are having any of these complications, fever, severe anemia, LRI, URI, infections idella suspect panina, review வந்து every 2 weeks once கூட நம்ம வர சொல்ல வேண்டியிருக்கலாம். These warning signs you have to advise. Vaginal bleeding இருக்கா, excessive இருந்தா, convulsions இருந்ததுன்னா, whether you are having any difficulty in breathing, fever, abdominal pain, or you are generally not feeling well னு நினைச்சா, breastல ஏதாவது problems, urinary problems இருந்ததுன்னா, or pus coming from the perineal wound, or lochia னு சொல்ற நம்மளோட discharges or foul smelling இருந்தா, these are the warning signs. You must come to us immediately. ங்கற advice வந்து should give to all the women. So these are all the take home messages I have already given. Some extra thing is completely antibiotic prophylaxis. Okay, this is not for you actually. Thank you.
Okay, thank you very much, Dr. Vijayalakshmi. It was very informative and enlightening presentation you have made today. When we look into the maternal death, most of the maternal death, majority of the maternal death occur during the postpartum period only. And it is important that all the knowledge of the whatever you have said, each and every slide is very informative, and hope all the participants have taken down some of the notes also. Very informative, and all the 42 days of postpartum is very mandatory that patient should be taken care of. And you have also explained so many things in Tamil, which is also very welcome gesture for you and for the participant, and it will be very useful for them. And thank you definitely, and definitely your presentation was indeed a great knowledge booster, and thank you very much for your kind presentation.
Thank you, sir.
Thank you so much, ma'am, for such an informative talk of yours. It was really very nice and very, very informative. Like for all the new mothers, this is something new for them also, and for our community health professionals. So I think the floor is open right now for discussions, and we have few questions from the participants, and I think we can address them. I think the first question is to Dr. Aris, sir. So they have asked that the BCG vaccine at birth of baby is not given. So up to 45 days, BCG vaccine is given or not?
Now, BCG vaccine, normally it is given at birth. It is normally planned before discharge. Suppose the child by any chances misses that opportunity to get BCG vaccine, which happens many times in institutional deliveries because of a series of holidays, festival holidays. Sometimes children do miss this vaccine, but the institution must take care to see that the vaccination is taking place even during holiday times. That's very important. Suppose they have missed, they have chance up to 1 year for taking BCG vaccine, but earlier it is taken, it is better for the child. Now it can be given along with other vaccines. Suppose a child has missed BCG vaccine at birth. Suppose the child has come only at 6 weeks for the 6th week vaccine. It can be given on the same day when the 6 weeks vaccines are given. So it can be combined on the same day as other vaccines and can be given to the newborn.
Thank you, sir. Sir, and ma'am, we have one more question. It shows like, what happens if we skip iron and calcium post-delivery? Any side effects?
No, it's not the question of side effect by skipping iron and calcium. Definitely, everyone will have some amount of blood loss will definitely be there. So supplementation of iron will prevent her from becoming anemic. Instead of tablets, it can be supplemented with your diet also. But with dietary this thing alone, the amount of iron which we take is definitely not adequate. So it is advisable not to skip an iron and calcium during the postnatal period. But it doesn't lead to any side effects as such.
Now, we can put it for patients like that. When they are asking side effect, probably they're meaning they're not taking, their health and recovery will be poor. So that's the effect, side effect.
Side effect,
So
yes.
for good effect, they must take the iron and calcium.
So thank you, ma'am, and thank you, sir. I think now we have come to the panelist session, that is speakers time, and I would like to invite Dr. Iyer to take it forward from here for the healthy group discussion.
Welcome. All the panelists have come.
Yes, sir. All I think.
Okay.
All are.
Vijaya
Welcome.
madam is not there. Probably she's unable to join.
Who is not there?
Dr. Vijaya.
Okay, okay. And welcome, Dr. Shanti and Dr. Sampath Kumari, and of course, my friend Dr. Arasar. And he has given already very exhaustive, very interesting presentation on birth dose immunization. And the panel, I cannot say it is a panel discussion. And now we are going to have only a group discussion because everybody says about birth dose immunization, and the Tamil Nadu being a state with about almost institutional, almost all the deliveries are institutional, and I can say it is a universal institutional deliveries are taking place in Tamil Nadu. Maybe 98 or 95% of deliveries are institutional. But in spite of that, we can't say that our birth dose immunization percentage is 95%. So there are some lacunae, there are some gaps, there are some barriers, and so we would like to know, because wherever the deliveries are taking place in the major hospitals, the major private hospitals and major medical colleges and almost all the government institutions, when the deliveries are taking place in the major hospital, of course they are getting this birth dose immunization, including Hep B and polio and the BCG. But what about the smaller institution? What about the smaller primary health center? Maybe there may be the reason for this low coverage. I cannot say it is a low coverage, but we are not reaching that more than 90% coverage. But I am not sure about the statistics. I think we can have a very detailed session on that, panel discussion on that with a statistician also on board to say what exactly is the percentage. And now I would like to know what are the best practices that can be followed. Of course, all the senior members are here. They know they are practicing, their hospital, in their hospital they are giving. So what are the best practices they are following and how to improve wherever there is a lacunae, wherever there is gaps, identify the gaps, how best we can improve the situation, any policy changes to be done by the government, any recommendation to the government, all these things, we can have only a group discussion. We can have some idea, and this can be put forward to a panelist when we conduct a panel discussion on this particular topic, and open to the panelists for their opinion.
Yes, madam, anyone can start. I think the most important thing is hepatitis B vaccine, because the need to give it within 24 hours if you really want to prevent mother to child transmission. So within 24 hours means most time the responsibility of administering should be in the labor ward setting or in the immediate postnatal ward, where this vaccine can be administered within the first 24 hours. But with hepatitis B, we cannot achieve that 100% coverage of all the newborns also, because there are certain indications where you can't give hepatitis B vaccine, especially very sick newborns getting admitted to the nursery. So leaving alone that group, and I think the rest of the babies who are eligible should be given that opportunity of being giving hepatitis B vaccine soon after birth. I think all nurses should be trained in the labor room to because in big institutions you have a pediatric department attached to the institution where the responsibility of giving the vaccine can be taken. But in smaller institutions, you don't have a pediatrician attached. So I think we need to depend upon the nurses there who are very trained to give this hepatitis B vaccine to the babies within 24 hours of birth. I think the obstetricians can add their views to this as to how to take this to the smaller institutes where the that can be given. And in many places, in large medical college hospital, the immunization days are all working days. Every day there's an immunization day. But in very small centers, in rural centers, the immunization is practiced only once a week. But that is why the government of India made OPV and hepatitis B as open vial, which means once the Indian and they can keep it in their refrigerator at +2 to +8, and the nurse can be trained to give it any day delivery is happening. That vaccine could be given, and the dose can be kept for 30 days safely.
Problem, sir. Can I add, sir?
Yes, madam.
Yeah. The problem was initially, sir, that is, initially it was given by pediatric nurses. That's what was done earlier. Then after that, it came to the physicians. It was made compulsory on the part of the physician, because naturally patients are there in the labor room for some time. So the nurses used to feel that this is an extra burden. Initially, there was much resistance because of that. There was a lot of tiff between pediatrics department and obstetric department. But then after some time, now in institutions, everything has been smoothened out. And now the target, at least in bigger institutions, I think is okay. Unless baby is admitted, after that, like that, it gets missed. But otherwise, compared to previous years, I think now it is much better. And usually what happened in Kilpauk Medical College, ultimately, we made the family welfare, A&M in charge of that. So that, she otherwise also, all these polio vaccination, everything, they only go for that during these booster campaigns. So ultimately, it was settled down only with such arrangement. Initially, there was some resistance among nurses,
Yes,
but then ultimately, this was decided, and then I think it's being carried out.
Yes,
And
madam.
all
I think you have rightly pointed out that they used to take the responsibility of protecting these babies soon after birth. The problem with bigger institution was when there is a pediatric department, it is a pediatric or the obstetric department. But then several methods were adopted where a pediatric nurse who was all the time stationed in the labor room, or a pediatrician who is stationed in the labor room, will take up this responsibility. But we will have to look at the whole gamut of all the levels of institution. And I think it is very necessary that we train every nursing personnel who is taking care of babies at birth, be trained in giving hepatitis B vaccine. And also the responsibility of giving vitamin K as early as possible also should be given. So in one thigh, you give vitamin K, near the left-hand side thigh, you give the hepatitis B vaccine. I think every nurse should be trained so that no baby is missed. Only babies who are sick and who need to be admitted to the SNCU, they need to be decided by the pediatrician whether that baby will be safe, whether there is any other contraindication for giving this vaccine. I think all other babies, I think it should become though under supervision of doctors, obstetrician or pediatrician, a nurse-oriented program, so that the nurse who is responsible for the labor room is trained to give this vaccine.
Sir, is it possible this vaccines in headquarters hospital and primary health centers where they deliver, are they giving within 24 hours, sir? Is it possible?
That's why the very purpose of this vaccine, madam, is to prevent mother to child and should be given within 24 hours. I think we must make them understand that critical period 24 hours is very, very important. Several, as you told, in several places it is missed and given even few days later. but that is not going to serve the purpose for which it is intended to. So if we really need to prevent mother-to-child transmission, it should be planned within 24 hours of birth, or at the latest within 72 hours. So this should be the strategy.
Dr. Vijay has joined. Welcome, Dr. Vijay.
Yes, sir. Good evening, sir. Sir, yeah, my problem at IOG is whichever baby is admitted, we are not giving zero dose polio and vitamin K. Even vitamin K we are giving to everyone, but other drugs, hepatitis B, polio and BCG are not given. So when we are sending the census to NHM, we are detecting the zero dose for the babies who are admitted. Nevertheless, they'll be getting their dues once a baby is stabilized. So we can't put in the census as zero dose. That is my main problem.
Madam, 1 minute, madam.
Sir, 1 minute, sir. Whereas, no, sir, in RSRM, irrespective of whether they are giving it or not, their census is always full. So I used to wonder how they can give and why IOG is not getting 100%. So I just want your opinion on that.
Yes, madam. Birth dose hepatitis B means it should be given within 24 hours. For hepatitis B, there is a indication, there is a contraindication. All preterm babies less than 32 weeks, it is not recommended to give hepatitis B unless the mother is HBsAg positive. So you cannot have universal all babies getting hepatitis B vaccine. That we must understand. And if they are sending, I think they are sending not the correct reports. So probably IOG is sending the correct reports of excluding babies that are getting admitted to SNCU. But there are babies getting admitted to SNCUs for some observational reasons, which means baby is not sick, but for the sake of mother. Those babies can receive hepatitis B vaccine either in the labor room or in the SNCU itself. So the medical officer in charge of SNCU must see, is this baby very preterm, which means he doesn't give that vaccine. If the baby belongs to a group where it is admitted for some minor ailments, that baby should be offered the advantage of this hepatitis B vaccine at birth. I think that is why I was told for zero dose OPV, you have 14 days time. For BCG, you have 1 year time. But for hepatitis B, you have only 24 hours time for administration. And for that being a contraindication for hepatitis B vaccine at birth for very, very preterm babies and very sick neonates, I think we can't be achieving 100% for HBV vaccine alone.
And one problem, sir, the thing is, see, everybody, all babies get universal vitamin K because that is after delivery, they are given the shot. But then hepatitis B is considered generally, even in private especially, that is only pediatricians should come and give. That is the general idea. Okay, in institutions is being given, that is a different thing. But in suppose if you say in private, where small nursing homes, even big nursing homes, only pediatricians give the hepatitis B. So
that's wrong. Wrong, madam. I think obstetrician must take up the role there also. Or pediatrician should be made to take a decision and give it within 24 hours. There's no problem. Someone takes responsibility, but the thing is, it should be administered within 24 hours and baby should not be denied the vaccine.
I know, but then that concept has not been told either by the pediatricians or neither the obstetricians know that they are supposed to give it. That is always it is thought vaccination, it is for newborn, is pediatricians'
role. Yeah. So that has been for a long time. I think now with the birth dose, especially with hepatitis B having a time frame of only 24 hours, I think as you rightly pointed out, someone be made responsible for administering that vaccine within 24 hours of time if we really need to prevent mother-to-child transmission.
All said and done.
Mild birth asphyxia, what is it take, sir? If the
yes,
baby
madam,
has,
mild birth asphyxia needed some amount of resuscitation that will go to the SNCU. But quickly that the pediatrician should decide if the baby has recovered within 24 hours. He can go, if it's a term baby or more than 2,000 grams, he can go ahead and give the hepatitis B vaccine. So that baby should be offered that choice of this hepatitis B vaccine at birth. Suppose the baby is absolutely sick or very preterm, then probably it should be avoided because science says that those children are not candidates for hepatitis B dose, because the dose that is calculated and kept in the hepatitis B vaccine in the very preterm babies, it elicits a very high immune response. The antibody titer is more than 8 to 10 times more. In the other group of baby, very preterm, it doesn't elicit any good immune response because newborn is still not mature enough to read. So balancing this, the advice has been given. But if the mother is HBsAg positive, known HBsAg positive, the baby should be given the opportunity to get both the vaccine and the immunoglobulin, irrespective of the gestational age and weight.
And excellent explanation, Doctor. Dr. Vijay has given a very interesting point which has to be taken care of, because she said some patients are being omitted because of their infection or some prematurity or some problem, and so IOG is never able to give send up a 10% result, whereas the other hospitals are giving. So whether we should have some criteria or some directive to be given, so that whatever madam is doing may be correct, because she is avoiding giving injection to children who should not be given. So what is your opinion about that particular thing?
Yeah, I think when we talk about birth dose, we need to differentiate BCG from OPV. BCG, OPV as together one component and hepatitis B as another, because it can't be the same vaccine coverage. OPV may be higher and BCG may also be higher, but hepatitis B definitely will be on the lower side than compared to other two, and that we need to accept it.
So does it have any side effect? If like a vitamin K, even for sick babies, if we give hepatitis B, will it have any adverse effect on the baby?
Yes, madam, that's what I told you. Suppose your adverse effect means doesn't have any adverse effect. Suppose you are giving it to a severely birth asphyxiated baby.
Yeah.
If you are giving hepatitis B to that baby, it does not cause any adverse effect to the baby.
Okay.
But normally speaking, one should not attribute a baby that is becoming worse and worse to any of the vaccine that is being administered in a public situation. So that's one of the fear, because most often a program should not suffer because of the ignorance of the community or public. Suppose a vaccine is given and the baby is becoming worse and worse, you do not know whether it is a part of an AEFI that is becoming worse or it is because of the disease per se it is becoming worse. So it leads to confusion. That's the reason why we need to avoid in very sick babies hepatitis B vaccine.
So actually, sir, what Dr. Mangla Bharati sir told was to avoid this confusion, better not to give any vaccines, viral, to the babies who are admitted in SNCU. We can
Yes,
give
madam.
it later. So that
Yeah,
the
give
statistic,
it later.
because some
Yeah,
people
madam.
are giving...
I think his statement can be taken well with a little bit of a thing. That is, every baby that is getting admitted to the SNCU, which means there are some problem. Let the pediatrician decide that, and all babies he will segregate to see which are all become eligible for hepatitis B, which are all not becoming eligible for hepatitis B. So that responsibility can be given to the pediatrician, but the pediatrician in the SNCU should decide in time.
It's good, I think, sir. We had a discussion with the pediatrician. So always the problem exists. So let's segregate. Whoever is admitted in SNCU, we are not giving birth dose.
Yeah.
Okay, because let it be the pediatrician's concern, because
yes,
whatever children are admitted in NCU and your total number of deliveries minus children sent to the NCU. If it is 100%, you are absolutely correct. and then let it be, because let the government give a directive, because that may be the problem, because as Arasar said, even though it may not be causing any problem, but AEFI, if it occurs, or if the child becomes serious because of the illness, and if you are given the injection, then all the public will come say, because of the injection only that became serious. So it is a very interesting point that you have raised up today, but it is fine that we will discuss it, and we will later on, we will come to, because it is an important point for discussion for the panel also later on, when we are going to have a panel discussion where we would like to ask the government to have a policy decision taken on this hepatitis B vaccination, because any late vaccination will not help in preventing the hepatitis B infection to the child. That is most important. Even if it is not mother and child transmission, it can be some caregiver may be positive. We do not know who is positive, who is negative. As far as hepatitis B is concerned, unless and until they are tested. So if the caregiver comes and takes out a baby and baby is not given hepatitis B vaccination, the child can have. And even the child, the problem with hepatitis B is child may not have any symptom and child will have some problem only after 20 years or so. So it is better that we take care of this particular point. And anyway, what is your opinion, Sampath Kumari, madam?
Yes, I want to ask Dr. Arasar. Sir, Arasar, sir.
Yes, madam.
That now this caregiver, suppose they are positive, we are not aware of it. And if they are taking the baby, means what what will be the further complications in future?
I didn't get your question.
No, sir, caregiver, somebody is not the mother. Somebody looking the baby, mother is not able to now, if it is LSCS like that, means some caregiver is there. No, somebody.
Okay.
If they are positive and they are looking.
Positive for what, madam?
HBs antigen.
HBs antigen. So, okay. See, HBsAg does not easily spread by handling.
It's blood spread.
Through breastfeeding, there is small chance, but the caregiver, by hand, the baby being handled by the caregiver, it doesn't spread the infection easily. So we need not worry about the caregiver handling the baby. From the mother to child through breastfeeding, small amount, but the major chunk, more than 90% of the infection is happening through the contamination of the blood and blood products perinatally at the time of delivery.
It's a good idea.
Shanti madam told this injection also within 24 hours. Even in the private small nursing homes, they are not giving.
Yes, madam. We have to emphasize this, that 24 hours is a crucial time if we need to have very good results for this prevention of mother to child transmission.
I think both IAP and Oxy have to come together, and because even pediatricians are not that.
Yes, madam. I think there is a lot of lacunae in knowledge regarding this hepatitis B vaccine. The need to give it within 24 hours. That is very important.
Some pediatrician before discharge we will give. That is the reply they
for
give.
BCG and OPV it is okay, but for hepatitis B it should be within 24 hours.
Yes, sir.
And not only that, suppose nowadays it is universal hepatitis B immunization. So invariably nowadays, at least the women who are becoming pregnant, invariably most of them would have been vaccinated generally. Okay?
Yes.
So if the mother is vaccinated, won't there be some amount of antibodies in the newborn?
Yes, madam. This antibodies in the newborn, only 2 to 8% are hepatitis B positive mothers. But rest of them either had infection and they are cured and have antibodies, or they are not having infection. This transplantally transmitted antibodies does not interfere with the hepatitis B vaccine uptake. So it doesn't interfere. So you can safely give.
Suppose the mother is immunized.
Immunized.
Hepatitis B immunization.
Yeah, that newborn will have antibodies to hepatitis.
Won't the maternal antibodies protect the newborn?
The amount of antibodies that is available is not the protective levels. So that is why the reason why vaccine is given at newborn period.
Okay. Suppose my one doubt to Dr. Arasar, suppose the child is in the ICU and NICU for some time. When can we give this vaccine? After some
no, the
child missed anyway before 24 hours, it cannot be given.
Yeah, within 72 hours. Suppose it misses 72 hours also, there is no role for that hepatitis B vaccine from mother to child transmission. The child will get next hepatitis B schedule, that is 6 weeks of time, along with the penta.
That's a very good point, sir. We should give within 3 days maximum.
Yeah, maximum 3 days.
Yes, sir.
This not my view. This guideline was given by the government of Tamil Nadu when hepatitis B vaccine was introduced at birth dose.
But many pediatricians are not aware of this.
Yes, madam. Several programs, many pediatricians are not aware. The purpose of Dr. Iyer, UNICEF and everyone taking this as webinar is to everyone know that this birth dose vaccination and the appropriate time of administering this vaccine.
Sir, if the polio vaccine can be given up to 14 days,
yes, madam.
why are they insisting on 0 dose, sir?
That's called 0 dose. The 0 dose
14 days is
yeah, given up to 14 days, it's called 0 dose.
Okay, so even 3rd day, 4th day, we can give, not a problem.
Yes, still it is a 0 dose. Yeah.
Okay.
Beyond 14 days, if you can't give, because it may not taken as a dose, as 0 dose, because if you are giving it at 2 weeks, 3 weeks, then it will interfere with the 6th week vaccine.
Okay.
So there should be a minimum interval of 4 weeks when it was formulated. Okay. So the Government of India and IAP gave this guideline, the 0 dose OPV be given from birth up to 14 days time.
Fine. Anyone else? Any opinion? Any doubt? Anything more?
Hepatitis B vaccine is a very stable vaccine. Even if kept at room temperature, it doesn't get degraded or loses potency. But for purpose of safety and ensuring high potency, it be stored at +2 to +8 centigrade in any refrigerator that is available in the labor ward or in any rooms very near to the labor ward. And
so it is okay with the multi-dose vials, sir?
Yes, madam. The vials are so designed. We call the bung. The rubber thing, lid is called the bung. These are puncture-proof, multiple puncture-proof doses. Even once you prick it and take off the needles, the holes close on itself and doesn't allow it to get infected. So these vials are safe for multiple punctures and they can be kept for up to 30 days.
Excellent.
So the maximum you will be puncturing, because it gives 10 dose vials, maximum you will be puncturing is 10 times.
Okay, sir. So initially when obstetrician it was they asked us to put hepatitis B vaccine in labor room. Initially it was first put by only pediatric nurses under control of pediatricians. After that it came to the obstetricians. But then the point which people raised was, see, all these people are very scared. These ANMs, VHNs, all are very scared of vaccination adverse effects. Yeah. So they said
they are afraid of vaccinating a newborn.
Yeah.
I think that fear should go off after good training.
Yeah, that is what.
Because vaccines are carried to the field and given at 6 weeks. It's the same newborn. It can be given at birth also.
Yeah. That is what, because there have been some adverse reactions for measles or certain vaccines. So that is the main thing. That was the first point which they put across. We are scared to put the hepatitis B vaccine. That
yes, madam. For other like BCG, there is a public demand. Public demand BCG vaccine. Simply because not they know it prevents tuberculosis, they think it is one of the identity to get that BCG vaccine. So there is a lot of demand. But with hepatitis B vaccine, that the same amount of demand is created, not created in the public because of ignorance. Not knowing that is more important than a BCG also, that we need to prevent this hepatitis B infection from mother to child. I think slowly by educating the public as well as all the healthcare worker, we can achieve this standards of good coverage to ensure that all children are getting protected.
Sir, why don't we make some models, sir? Iyer, sir, அந்த காலத்துல மனோரமா வச்சு போலியோக்கு போட்டாங்களே அந்த மாதிரி we can make some.
Yes, madam.
What I feel is that, birth dose immunization, when they say birth dose immunization, it is a gynecologist, the role of gynecologist is major and they are very important. That is what people say. But from the discussion that I feel now, they're doing their job fantastically. They are well aware of this vaccination. They want the children to be given the vaccination. They are only telling us the barriers, how they cannot give in the major hospital where pediatric services are available. Once upon a time when I was in service long back, there was a postpartum unit with A&M, and it was their job to do that. I do not know whether that is, it was there in up to the Taluk hospital level, sub-district hospital level. I do not know whether such units are available, because immediately that A&M will come from the postpartum unit, will take care of the vaccination. I do not know about
No, that
the
is
current
right.
situation.
Only ultimately, only they are made in charge of that. Ultimately, they are the people who maintain the records, and they only look after. This is
Yes, madam. If you see the evolution of this birth dose, BCG started first. After some years, zero OPV got added. Now, after that, only now hepatitis B is added. So it was not all introduced at the same time. So there is a time lag at each interval. This has been introduced, and so that's how the resistance after introducing hepatitis B has come, because people were used to only BCG administration first, then zero dose OPV. Zero dose OPV, everyone became confident because pulse polio was given by everyone and anyone in every situation. So they know pulse polio is very safe. And I think the same type of thing we need to develop in everyone's mind, that hepatitis B vaccine is also safe. In general, all vaccines are safe if you take all the precautions of storing them properly, reconstituting them properly, and administering them properly. I don't think that there should not be any fear about vaccines at all.
Okay, from what Dr. Arsar said, regarding the percentage, we cannot compare this BCG polio with hepatitis B. Definitely, there will be some shortage.
Yes.
But that we'll have to have an increased awareness generation among the service providers. The gynecologists, they will be supportive, and they will definitely, we are with the patients for the 9 months and 7 days, and they know, and they will be in the labor room also, because their advice, their counseling will be most important, will be heeded to, the patients will be more attentive to the advice given by this gynecologist, because they have been with them. But of course, the role of pediatrician comes after that, and it is, and they are the people to decide whether the children should be given the vaccination. The normal children is no problem, normal baby no problem, but if there is having any problem, the baby has to be given the vaccination or not. That has to be decided by the pediatrician if there is available, because it has to be decided by the pediatrician. If there for some abnormality, the doctors working in the smaller institution without any pediatrician are afraid of giving the vaccination. So that is the reason we'll have to have a more awareness generation among the service provided in the smaller institutions. And I think a very good panel discussion is required.
I
just
want to do one small point here, sir.
Yes, madam.
Sir. Yeah, in Lakshya, when we were checking the zero dose polio, they were telling there is no need to keep the vaccine carrier. Because you're giving now and then labor room, you can use the vaccine straight from the fridge. Is it safe, sir?
Yes, madam. It is very safe. That's why I told you, hepatitis B vaccine is very, very heat stable vaccine.
So no need for ILR.
No need to keep
sir,
it at ILR.
Madam is
Simply
asking
now,
about OPV.
OPV.
Yeah, everything,
No,
all
no.
vaccine,
Suppose,
no need to use ILR in the labor room. Take it from the fridge and give it and immediately keep it inside.
Yes, madam. That's what is done in every private clinic also. No one keeps it on the, unless you leave it there in the room temperature and hot climate, where you have the chance of losing its potency. If you are directly going to not waste time, put it in the mouth and put it back in the fridge, nothing happens. Okay, so you need not take it on ice pack or anything up to the child's mouth and put it. That's not necessary.
Okay.
If you are using it in the labor ward, storing it in the labor ward.
Yeah.
But
suppose you are taking it to a distant place, then we need to transport it properly.
Ice carrier. Okay.
And, and also see that the fridge where vaccines are kept are not opened and closed repeatedly.
Frequently, yeah.
Arsar sir, again that's basic small doubt only. Why hepatitis should be given within 24 hours?
That is because mother to child transmission. Otherwise, the virus that enters the baby gets established. So it starts infecting the cells and get established. Even before the virus establishes, we need to prevent it from infecting the cells.
Yeah.
So that's the reason why this vaccine should be given within 24 hours.
So this should be given.
If mother is hepatitis B negative, no, then is that?
Now that's the reason, madam. If mother is hepatitis B negative, if you are very sure she is negative, then the zero dose, the birth dose of hepatitis B becomes superfluous when you are sure. But if where the status is not known, but if there is a long window period between ascertaining the status and the delivery of the baby, where in this window period the mother is infected, then the chance of spread of infection. That is why it is given, and the crucial period of 24 hours is fixed.
I think
Okay.
Shubhashree,
For
I have
all
noted-
antenatal women, we are doing hepatitis B.
Yeah, madam. In many bigger places it is done, but it is not become universally available to every woman. That is why till
Okay,
a system is there.
at least
Yeah.
if the mother's hepatitis B status is known and it is negative, this immediately, if we are not able to give
Now
it,
that
then
depends on how early you have done that status. Like how we call in HIV also. If I screening with HIV today, I'm negative. Does it mean I'm lifelong HIV negative? No.
yeah, that is there.
Yeah. The
But
same
we do
holds.
it only at booking.
Yeah.
We do
So,
do the
At
hepatitis
booking,
B.
everybody only.
yeah.
But
At
9
booking.
months.
Yeah.
Yeah, it's already 9 months.
Yeah.
So maybe a long window period, as RSL sir
Yes.
says.
Yeah.
But then, sir, if you do an anti-HBs routinely, you know the mother is protected.
Yeah. Man.
So that might not be possible for.
Now you take the cost of doing the anti-HBs for every pregnant mother and then deciding on the vaccine, or which is logistically more superior, is to give every child the hepatitis B vaccine.
No, that is there. But
Yeah.
then what they say is
because this hepatitis B vaccine does not cause any harm to term infants. And
Or can we do HBsAg near term, sir? Like
no,
we do
no,
for
not
COVID.
necessary, madam. That becomes
Like we do
two
for
set
COVID.
procedures.
No.
Yeah, not necessary. Not necessary, unnecessary to waste the resources on that. Best
No,
thing
sir.
is to
No. The thing is, instead of doing it at booking, why not do it 4 weeks prior to delivery?
That's what.
Madam, no. You are talking pure science. When you take pure science, your logical the differentiation is good. But when you take to implementation, is it possible to have 100% every mother having done one hepatitis B status very close to delivery? All that is more critical in happening. So I think best thing is to choose the best option. I think giving of the vaccine.
Yeah. Just as you said, even if 4 weeks back, even then, next day she can get infected. We do not know.
Yeah.
So anyway, it is better that that option is. Anyway, that today's group, it is only group discussion, but it has more or less become like a panel discussion. I think this is being live streamed, and Dr. Arasar has given a very lot of important points about it, and our senior obstetricians have raised that what could be the barriers, what can be done. Their suggestions are also very, very well taken, and I think we should, this information that is being given through this group discussion will be very useful to the public, and I am sure the importance of hepatitis B vaccination will be made aware of for all the service providers on the maternal and newborn care. And Shubhashree, and regarding the panel discussion, we can have a invite more people, and with a lot of statistics and more, even some sociologists and some other people can also be invited, and we can see how best we can improve the coverage of hepatitis B vaccination, which is very important. Thank you.
Sure, sir.
And what do you say, sir?
Sure, sir. Point noted. And I think Kaushik is also from UNICEF on the panel. So I would want him to have, express few words. He's on mute. So
Kaushik? Yeah.
Thank you, sir. And thank you all the panelists for a wonderful discussion. It's very illuminating and good to see a very good exchange of scientific opinion about a very key input that we feel is absolutely essential for ensuring child health. There are multiple issues, I think, which has been flagged and raised through this discussion in terms of training of or hesitancy amongst the nurses for giving the dose injection to a absolutely newborn. reporting in terms of health informatics, what is the correct way of reporting is a key issue that I could gather from the discussion and the issue raised by Dr. Vijay from IOG. In terms and alternative methods of prevention and issues of availability of the vaccine or cold chain, and also perhaps also bit of awareness generation at the ANC stage with the mothers and or the parents on the birth dose is perhaps a key factor in this. There might be, we know in Tamil Nadu vaccine hesitancy is not as strong as some parts of the other country, but when it comes to absolutely small newborn babies, there might be some bit of resistance. So multiple factors can play a role in this, and I absolutely believe I take away all the key points that have been raised by each and every one of you, and it would be great if we could come together in a bigger group, in a bigger panel, to find out, to brainstorm and find out how best to address some of these issues, and perhaps propose a joint initiative to a joint submission towards the government and the professional associations like Ogsi-Ekam to propose a way forward on this. I would rest my case there, and thank you to both Dr. Arasar and Dr. Iyer sir for a wonderful discussion moderation. Thank you from my side. Thanks.
Thank you, sir.
So thank you all. I think with this we are coming to the end of the 2 days webinar, and my sincere gratitude and thanks to UNICEF and all the doctors and the panelists who has attended this webinar, and of course our participants. I know all this informative talks is actually recorded and it is live in our YouTube. So once again, thank you all to everyone who's present here, and thank you UNICEF and doctors.
And one more point, because I may be failing in my duty if I are not thanking Meryl and also Shubhasri for taking over this program in a very well organized manner, in spite of having some problem yesterday. And it was a well organized program. We were able to finish it up in timely, and Shubhasri did a fantastic job, and of course I should say Meryl has done an awesome job, because fantastic, awesome, everything is same. Anyway, thank you very much.
Thank you, sir.
Thank you, everyone. Thank you.
Thank you, sir. Thank you.
Thank you, Shubhasri. Thank you, Meryl. Thank you, UNICEF.
Thank you.
And thank you, Ekam Foundation. On behalf of Ogsy, we have had a lovely 2-day sessions. Thanks a lot. We look forward to collaborating with you more. This is thanks on behalf of Ogsy. Thank you.
Thank you.
Thank you, madam.
Thank you.
Bye.
Thank you, ma'am.
Bye.
Thank you, ma'am.
Thank you.
Yeah. Thank you, ma'am.